As we start off with our health conversations this morning, male hypogonadism is a condition in which the body doesn't produce enough of the hormone that plays a key role in masculine growth and development during puberty, which is basically testosterone, or enough sperm, or both. Now, joining us to shed more light on this, we're joined by Dr. Bonifatius Steenkamp, who is a urologist. Good morning, doctor.
Good morning, and thank you for inviting me, and good morning to the viewers.
Thank you so much for making time to come out and talk to us. I just basically gave out the definition of what hypogonadism is, but how does it impact a man's health as well as development?
Sure. Hypogonadism is a very crucial men's health topic. The impact depends on the stage in the human male life cycle. It already starts sort of in utero. That's even before the male baby is born. If it's in utero, then you normally get some congenital abnormalities. You can get testicular dysfunction. You can get undescended testes, which just means that the testis doesn't descend to the scrotum or the scrotal sac. You can get hypospadias, which just means that there's an abnormal opening of the pee pipe or the urethra on the penis. If it happens before or during puberty, then you get so-called delayed puberty, where there's a delay in the development of male organs, the penis, the testes, the scrotum. Also a delay in sort of the male deep voice, delay in the masculinity, like you said before. If it happens later on, like adult onset, then you get a problem with maintenance of these male functions. In other words, sexual functions, cognitive functions, and so on.
All right. But what are some of the most common causes of male hypogonadism, and how is it diagnosed?
So basically we classify the causes between primary hypogonadism, which just means that the main problem is actually primarily at the testes, so there is testicular dysfunction. Remember, the testis is the main organ or source of testosterone. About 95% is produced there, 5% in the adrenal gland. So primarily, and usually the primary ones are either congenital abnormalities, or sometimes testicular tumors, cancers, or it can be that there were some infections in the testes, trauma, and or torsion, which is basically to say that there was an injury to the blood supply of the testes. Then you get secondly the secondary ones, which just means that there is now a problem with either centrally the hypothalamus, pituitary, or the gonadal, that axis, because the release of testosterone is controlled or regulated by the brain. So if there's a problem in that axis, then normally you can get this hypogonadism as well.
All right. But are there perhaps any risk factors that make men more susceptible to hypogonadism?
Of course there are, and especially in the late onset or the adult onset hypogonadism, things like obesity, certain comorbidities like hypothyroidism, things like chronic kidney disease, and especially those who are on hemodialysis, can also sort of predispose or risk them to have hypogonadism.
All right. But what are some of the typical symptoms of hypogonadism, and how do they differ from an adolescent as well as adults?
Yeah, so in adolescent one, we said that it usually has to do with the development. So there is delayed puberty. So you will have not growth of the penis, of the scrotum, the testes. You will have that high-pitched voice, not a deep voice. You will have a different hair growth pattern. And then in late onset or adult hypogonadism, I usually like to classify it into clinically the general ones, which are things like a reduced testis volume or scrotum size. Then you get things like infertility, and then you get visceral obesity. You can get the metabolic syndrome, which just includes things like insulin resistance or type 2 diabetes. And then the second one is obviously the sexual function. So here you get loss of libido. In other words, that sex drive or appetite or desire is lost. You get erectile dysfunction, where they just have weak erections. And or you get also diminished or decreased nocturnal erections. In other words, those erections that we get during sleep and or the morning erections. And then lastly, it's the cognitive function, which is also important. There's diminished cognitive function, there is sleep disturbance, there is just changes in the mood or the fatigue. There's so much fatigue, or there's just changes in anger management. And you also sometimes get depression. So those are usually the main things that you get. But remember, in the adult onset hypogonadism, testosterone usually is also important for bone mineralization and muscle strength or growth. So if they have a low testosterone, they normally also get things like what we call osteoporosis or osteopenia, where they are so prone to pathological bone fractures that are caused by just a low sort of trauma incident. So those are usually the things that you get, or the signs and symptoms that you can get with low testosterone.
All right. But what are some of the tests that are commonly performed in order to diagnose this condition?
Sure. If there's any suspicion that there might be low testosterone or the so-called androgen deficiency, one has to first take a history, of course, to be able to find the symptoms that we talk about, examine the patient or the client to be able to see if there's any signs that you get, and then you have to confirm this with a blood test. So it's a peripheral blood test that you do, and usually we have to do 2 of them, and it has to be done in the morning, ideally before 10. We know that normally the peak release of testosterone happens in the morning, and then later in the day there's sort of the trough. If you do it later on, you will get sort of a false low testosterone level, which you can't really use to make any clinical assessments.
Right.
And then once you have got these levels, we just roughly sort of say that if that level is between 8 and 12 and there are symptoms, then the person probably needs to get testosterone therapy. If it's less than 8 without symptoms, you also have to do. But if it's more than 12, then we don't normally initiate any testosterone therapy.
All right. But are there perhaps any specific age groups or situations where screening for hypogonadism is recommended?
So usually the puberty, at puberty, if one suspects that there might be low testosterone, one can do it. We know that in the adult onset, things like infertility, erectile dysfunction, decreased bone mineralization where they have sort of weak bones that are prone to fractures. There we also sort of screen them actively, and especially in infertility or in erectile dysfunction situations.
All right. Are there perhaps any treatment options that are available, and how effective would you say they are?
Yeah, as I mentioned, once you have the level and once you have sort of assessed the male patient to see if there's any signs and symptoms, there are several treatment options. They are both short-acting and long-acting, and there are different preparations that one can use. In other words, some that you do intramuscular injections, and they vary between whether you have to inject every month or every 3 months. And then there are some that are taken orally. Then you get also what we call transdermal gels or patches. And those ones, some of them are done daily, every 24 hours. And then one also gets implants. So initially when we initiate testosterone therapy, we use the short-acting ones, because you want to be able to stop it when there are any adverse effects. And then obviously if once you have monitored the person and there are no severe adverse effects, you can now proceed to the long-acting ones. The reason why the long-acting ones are good is that they give you that steady, stable phase sort of testosterone level in comparison to the ones that are short-acting, where it fluctuates a lot, and then you don't get the exact effectiveness that you want of the testosterone therapy. The transdermal patches and gels, the problem is just that sometimes you get the interpersonal transference if you don't really protect yourself well at the area where you have applied the gel or the patches. The problem with the implants, again, is that they can sometimes get infections at the site of implant, or there can be extrusion of that implant.
All right. What happens if the condition is left untreated? Does it lead to other health conditions also?
Of course it does. So one, we, for example, said infertility. So if not treated, there will not be restoration of fertility, and that couple will have infertility. Once you treat the person, then they will still be able to obviously impregnate the wife. The other things are really function, just male function, in other words, sexual function, cognitive function, bone and muscle function, and so on. And obviously your moods and depression and those things that you really want to by all means avoid.
All right.
So,
all right. What are some of the lifestyle changes that men can perhaps just put in for the works in order to help them cope with hypogonadism?
So, like I said, one of the risk factors in adult onset is usually obesity. So weight loss will be crucial to be able to prevent that you don't get low testosterone. Then one has to treat comorbidities correctly and be able to control them. And then obviously lifestyle changes like decreased or moderate use of alcohol. Then smoking is one of the most important risk factors. So one would probably advise that you should stop smoking and avoid abuse of recreational drugs like marijuana, and also the abuse or long-term use of opioids, which are just strong pain medication. They have been found to be risk factors as well. And perhaps very crucial as well is adequate sleep. Previously we used to say one needs to get on average 8 hours of sleep a day. Now we are saying probably 6 hours a day. And as I said, the peak release is usually during the morning hours when we are still asleep, and then you just can maintain a good baseline testosterone level.
All right. Is this a lifelong condition?
It is lifelong, but obviously if you have now gotten testosterone therapy, one can treat it, and then one can sort of make sure that you still have a healthy sort of life forward.
All right. What do you think is the biggest misconception about male hypogonadism, and how can we raise awareness on it?
Yeah, I think the biggest thing is one must remember that normally as you age, there is a normal decline in the testosterone level. We just don't have the exact sort of cause or natural cause of decline as one has in female, where menopause is well defined, but we know that it does decline. And once you start seeing these signs and symptoms, or once you have problems like infertility or sexual dysfunction, then it's probably best to see a urologist or a health professional just to be able to be assessed and those biochemical confirmation to be done, and then one can obviously proceed with therapy.
All right. So, doctor, what are your orders for today? What are your doctor's orders?
So what I would say is that one should probably be able to, once you have find that you have some of these symptoms, see your general practitioner or see a urologist, and confirmatory levels of the testosterone will be done in the blood. And remember that one can identify, for example, that you have infertility. And then, as I said before, we classify the causes into primary and secondary. And most of the time, if it's secondary, one can perhaps detect tumors that are in the brain, or one can detect comorbidities like hypothyroidism or testicular tumors. And these things are most of the time treatable, either medically or surgically. And once corrected, the man can again sort of live a normal life.
All right. Dr. Steenkamp, thank you so much for making time to talk to us this morning.
Thank you very much. I appreciate it.
All right.